stuff y'all learned. And I don't know if this came with the, oh, here's your papers. On the back, you stop on that one and then do this one, and that's it.
Oh, wait.
But yeah, you don't do anything else. Did they jump on? Oh, here? Yeah, okay. So, there were two things I noticed that were not wrong, but not one of them wasn't right. So I just wanted to clarify with, someone said that strep is the major cause of pyelonephritis. And it could have been a day class person, I have no idea. Oh, I'm sorry, Kim. So, actually, I mean, you can get strep with pyelonephritis, but what is it that, I think they got it confused with another disease we talked about. That was acute. Acute glomerular nephritis, that's right. That's what is commonly strep. That's the one that's, there's an acute and a chronic, and the acute comes from some type of infection. Strep is a common one. Like with kids, when they get a strep throat, you're going to need to keep an eye on their GU after that. And then the other things that NSAIDs are nephrotic to patients with kidney issues, and it's that they decrease kidney perfusion. Not, I think of being nephrotoxic, like in antibiotics. But yes, NSAIDs, and the way they do that is decrease kidney renal perfusion.
Since you said that, I'm trying to think of the disease process, but it says that sometimes they give it in the early, I think it's acute, it might be
What do we do?
NSAIDs, but it says it's a risk. It decreases inflammation in one of those early disease processes.
Okay.
Anybody know what I'm talking about?
Nope.
Sure don't. But anytime you use an NSAID, it is, if you've got a lot of inflammation, it is going to help with that. Stones, we use Toradol. But you've got to remember that, Torlax, that it can decrease that perfusion of the kidneys, and if you've got a kidney patient, you have to really be careful with that.
How does it decrease perfusion?
How?
Yeah.
I don't know. No, it affects the vasoconstriction and stuff, but I don't know the total pathway to that. We don't need to get cellular with that.
Okay.
Just know that it does. Okay. All right. So I think this is where we were. It's where I was this morning with the group. Is this right?
I think
Looks right.
You have no idea.
renal trauma.
What?
Samantha is right. That's the last place I saw.
Okay. So there's acute kidney injury. When the kidneys start to recover, they sometimes will go through a polyuric phase where they polyuria, where they are making a lot of pee, but it's not good. They're not concentrating or anything. But this is like with the immune response, when you have diseases like acute glomerulonephritis, and you get that mediated immune response. These patients can react to that by going through this polyuria phase where they have albumin has, especially acute glomerulonephritis is very common for this to happen. We've got albumin, the glomerulus have let albumin get into them because they're not filtering correctly because they've been damaged. And when that albumin gets in, remember it sucks water with it. So it takes a lot of the fluid out with it, but again, it's not good, okay? It also lets protein get in there, which is not normal. Protein, that's the albumin, and red blood cells is also what sometimes gets in there. So they have a high volume output, but they still, because that volume's gone, their electrolytes will be high, and they'll be dehydrated. because we've let all this volume follow that protein now. So where we were watching their fluid intake because they were not, they were holding on to water. When they get to this phase and you see a ton of fluid, of urine coming, now you got to worry about them getting dehydrated. So we're going to fluid resuscitate and watch those electrolytes very closely. So that's the main problem, fluid electrolytes. And the fluids, they're now going to probably be dehydrated. So we're going to carefully give them fluids back and keep trending that output so that we don't overload them. Okay? So when you talk to, if those patients have to go down, another thing I realized I didn't mention last week, but sometimes they still have to go down for contrast mediums, even when they have renal issues. And we use Mucomist to protect those kidneys, and also let the radiologist know about their VU and creatinine, what's going on, that they can use less of the contrast medium to try to protect those kidneys. All right, so adjusting drug therapy doses, remember they can get toxic quicker because they're not metabolizing drugs out through the kidneys. Watch for nephrotoxic drugs that they may be on. Sometimes if the urine output stops or goes down, we can fluid challenge them by giving them 250, 500 cc's of fluids and try to get that cardiac output back up. And you may see them check to see how the patient's going to respond to that by raising their legs for 60 to 90 seconds. That should help their blood pressure go up, right? So they may see, well, let's see if that's going to help. If they are fluid overload, you'll see diuretics being used. Watch for potassium wasting, and that should increase their urine output. Digoxin is going to help increase that cardiac output, which was one of the pre-renal things that can cause them to be an acute kidney injury. Remember, we're talking about acute kidney injury here. And then we had all those things, the hypovolemia, the decreased cardiac output for pre. The intro was acute glomerulonephritis. The post was stones, obstruction, a mass. We're going to treat all those causes and then support the kidneys while they heal, okay, for acute kidney injury. Nutrition-wise, and this is going to be with, hit it too many times. As their kidneys are failing, we have to watch that GFR, remember, to decide how much protein to give them. When we give them protein, we want it to be good, high quality, natural proteins, eggs, fish, chicken. We're going to be careful with their dairy because milk, dairy products are high in phosphorus. And if their phosphorus is going up, their calcium is coming down, and we know that is a big problem. Potassium is the first electrolyte. We talked about that will start to go up. It's usually the first one you'll see. So we might need to start limiting some foods high in potassium and work instead with foods that are lower in potassium. Remember sodium. Decreasing sodium is going to help with blood pressure, volume. They don't need to be using salt substitutes though, because they have what in them? Potassium. And we don't need extra potassium. All right. So these patients, we treat the problem that caused it, and then we do conservative management. We manage their comorbid disease, their diabetes, their hypertension. We manage their nutrition, their fluid volume, their electrolytes, through diet. But some of them will end up and will need some type of renal replacement therapy. Now there's a couple of ways we can do this, but usually with acute, they may start out with a central venous line that has double lumens so that you can have an input and an outtake. And we'll do a hyperperfusion type of dialysis. Hemodialysis can be done through that line also, and sometimes we have to do hemo, but because it works better. But if the patient, and they usually aren't very stable hemodynamically, because that's kind of how they ended up in this place in the first place. So hemodialysis works over 3 to 4 hours. You do it, and it shifts a lot of fluid. A lot of things are shifted. And patients that are critically ill may not be able to tolerate that. So we have what's called the continuous renal replacement, or it can be done intermittently. But it is cardiovascular venous hyperdynamic filtration. It's a continuous that doesn't shift things as quickly. Okay, it's slow. It helps to clean that blood, but it's a lot slower. So if we get a patient that we've been trying to help with conservative management, but they are still uremic, they're getting more and more acidotic, we can't keep those electrolytes under control, they're just declining. Their potassium is over 6.5. Their pH is 7.2. I mean, they are acidotic. Then we're going to put them on some type of kidney replacement therapy, because we need to get something in there acting like a kidney. Theirs is not working now. Okay, and So they work about the same. This is if I were to do hemo. They access the femoral artery and femoral vein. It's temporary. If you're going to put somebody on hemodialysis permanently, they're going to have a fistula or a graft. But we hope that acute kidney injury patients, it will be temporary. This is a CV line, neck line that we can. The 2 ports, one is for arterial blood that is going to bring the cleansed blood back, and the other one is for venous, which is an inflow. Take it through the dialyzer here, and then put it back into the arterial side so that it sends good, clean blood out to all the organs. Now, this is an example, and I'll pass them around a little bit, but they work kind of the same as far as it's diffusion. Higher to lower concentration is going to move. So if I've got a potassium of 7.2, then my dialysate that's running around here is going to have a lower potassium, so that I can pull off some of that potassium level. With this CVDH, continuous replacement therapy, it's slower and works better with hemodynamically unstable patients. So they still have a site that you'll need to monitor for bleeding, and but hopefully that temporary continuous replacement therapy keeps them from going into chronic renal failure. So post-operatively, these patients sometimes go home still on temporary dialysis, and they have to come back and be dialyzed every 3 days. 3 times a week. Some of these patients go home, they're fine, never have any more problems. Some of these patients, though, will end up with end-stage renal disease because they've had too much damage, and they end up on dialysis. renal dialysis. So it's real important for you to recognize those patients, hey, those patients that can get AKI, that are at high risk of it, and get that replacement going quickly. Because the sooner we catch it, the better off they'll be, and the less likely they'll be on renal replacement. Okay? So, of course, there's going to be follow-up with it. If there's permanent damage, they'll be on dialysis, and some patients go home perfectly fine, and they never have another issue with it. So it really just depends on the status of the patient when they leave, and how long they were there, where they started on dialysis while they were there, how much damage did they have. All right, so any questions on anything we've covered so far? When you've been studying, any money points that you just didn't understand that we need to look at again? Y'all are awesome. Or I am. I don't know. Okay. I have a math problem on the next slide I didn't leave. Anybody working? All right. What'd you get?
I got 25.90.
Close. I think. Let's see. Oh no, you're right. I was thinking 26, but you are right.
Yeah, that's what I got too.
That's what you got too?
Yes, ma'am.
Well, let's see you work.
Oh,
I'm gonna let
okay.
y'all that didn't do it ahead of time, go ahead and work it. Oh, I didn't get it. I'm in the classroom. You are the lucky winner of some kind of some pretty neat. Oh, awesome. So I won't need you to do this out. Front and back. Okay, so this is how you set it up. I got 250 milliliters, if I'm looking for milliliters per hour. 250 mLs in 50 milligrams, then I have to make a conversion. 1 milligram is 1,000 mics. 2 mics per kilogram per minute. I got rid of my minutes first because I needed hours, but I still have kilograms in here. So now I got to convert kilograms to grams, and my patient weighed 95 pounds. Kilograms to pounds, I'm sorry. And I come out with 25.9. Okay, so if you set it up right, that calculator will lead you to the right number. If you didn't, give me a little shout out and we'll work on it.
How many math questions should we expect per test?
2, at least 2.
I want more.
You want more?
Those usually kind of help out. They're good for planning.
Well, there'll be 3 on this one because you're gonna have a CBI question. She'll go over that. Okay.
CPI.
We hadn't gone over there. All right, but we are gonna go ahead and talk about, get started on chronic renal failure now. Okay, so chronic is progressive, irreversible. You remember when I had the GFR, started at 100 over here, and we worked our way across and went down. 5 stages of renal failure. The kidneys fail in a predictable manner, and they eventually develop what's called azotemia or uremic syndrome. Miss Kim used to say she would call it urine in the blood, because basically you were supposed to have cleaned out all those toxins and they would normally be in your pee getting rid of them, but now they end up in your blood, okay? And they're going to cause anorexia, nausea, muscle cramp, itching, edema. They're going to cause all kind of problems. The toxins themselves are toxic to the vessels, and they cause a lot of inflammation in the vessels themselves and cause pericarditis and pleuritis. And we're going to go over each of those systems, actually I think 2 or 3 times, so you really get it down what's happening when our kidneys fail. The deal with it is that you may not see any of this until 75% of your nephrons have been killed. So that means you've only got 25% left. So you're in trouble at this point. And it's usually a stage 4 or 5 before we see this. So in the first stage, you may have a little bit of damage, but your GFR is still okay. Okay, we're still clicking along, we're still making urine, we're cleaning everything up. In stage 2, my GFR is going to start dropping. I'm still not seeing anything. I may have gotten put on antihypertensive because my blood pressure started going up some, but I'm not really seeing any big problems with it. Stage 3, they've divided into A and B, but it's just going from that 60 on down to 30. So these first 3 stages, it's usually down here before I start seeing things like swelling feet, nausea, and maybe a little bit of anemia. But start seeing some of those problems that develop when our kidneys don't work. So we need to start managing, way back here, right here, if our patients come in with diabetes and hypertension, we need to start managing that immediately. They need to really understand how that relates to their kidneys and really start helping them control it. Okay, that's very, very important. We can't get it back. If we wait and start till they come in with all these symptoms, we've probably lost that kidney, those kidneys. So we need to start early. Now y'all don't have this next slide, don't freak out. But this is just a renal failure as we progress. Renal insufficiency kind of started off in those first 3 stages. We were not really seeing a whole lot, but when they start showing up, we're going to see some headaches from the fluid overload, maybe from some of those toxins. They're not going to be able to concentrate their urine as well. They may start out going a lot and having nocturia where they have to get up at night, but then their urine output drops. BUN and serum creatinines are going up, mostly creatinines. They start noticing their feet swelling or having some edema in their legs, periorbital edema around their eyes, their GFRs progressively going down. Potassium, it's one of the first electrolytes that you notice, and it's important in what? Why do we care that the potassium is 7.0? Heart, dysrhythmias, a mild anemia. You remember we messed up the production of red blood cells because we don't make erythropoietin like we did. And your blood pressure start being a little harder to take care of. Weakness, fatigue. So these were what the patient will start noticing. As we move into 4 and 5, these are more serious chronic end-stage renal disease. Severely reduced function. They are definitely having symptoms now in every system. And we are working patiently with managing comorbidities, education, discuss options, and prepare for renal replacement. Because at this point, their GFRs are down to 30 to 15. They're going to end up on dialysis. And they have choices. We're going to talk a little bit about the different kinds of dialysis. We can do it at home. We can do it in center. We can do peritoneal, which is using all that lesser and greater omentum vasculature in our abdomen. And then stage 5, usually the GFR has gotten to 15 or less, and they need to be on some type of renal replacement therapy. That's why we start talking at stage 4, because it takes a while to get a graft or a fistula or put the PD tube in. It's not going to happen overnight. So we need to start talking to them before they have to have the dialysis. You know, deciding, okay, these are your options, which do you want, what can we do, and those kind of things. Now, just because, well, I'll get to that in just a minute. Another marker that they use to look at renal function is called albumin to creatinine ratio, which they're looking at how much albumin you're spilling into that urine compared to creatinine. And they have found that with microalbuminuria, that's A1, stage 1, that's usually like the 1 through 5, that's probably around a 1 or a 2. But it starts to go up as your GFR goes down. So you've got a 2 ratio, and then you've got a 3. That means you're spilling a lot. That means you've got a lot of damage to your glomerulus and your kidneys. And you're probably at that point in stage 4 or 5 of end-stage renal disease. So that's another marker they've been starting to use, and it reflects really well the GFR. So let's look at what happens with chronic renal failure. And then we'll go through each of these systems. But you see, all of them are affected. Neurologically, the weakness and confusion is going to come from decreased perfusion to the brain because of vascular damage, from the toxins that are getting left. The fatigue is going to come from the anemia as they get anemic. We're happy if we can keep a renal patient's hemoglobin around 10. And that's still anemia. But that seems to be, they do well. They do okay with that. We can't really get it a lot higher than that. Of course, we're going to have increased blood pressure. They're going to have edema. They're going to have central venous pressures increase, and the pericarditis I told you about. Pulmonary, of course, shortness of breath. They make a very thick sputum, which is really hard to get up. So they have an increased risk of infection because they have lower white counts. And they also can go into pulmonary edema. So we'll have that red tinged sputum that comes up. GI. They are not metabolizing the ammonia. So they get that odor, which gives them a metallic taste. And they get anorexia. They don't want to eat. They're tired. They just don't feel like eating. And they're very prone to ulcerations in the mouth, and in the they get peptic ulcers a lot, and they can bleed and perforate the peptic ulcer, and you've got a big problem. because they don't clot, so they can hemorrhage a good bit. Psychosocial, psychological, this is a chronic disease. It's not going to get better. So they do have a lot of psychosocial issues that dialysis nurses need to help them with. The hematological, we'll talk about the anemia, the bleeding tendencies, serum, potassium's increasing. The skin, dry, flaky, all those toxins can start to seep out and they'll get this white, frothy look on their skin, and you just need to wipe it off. They kind of get a yellow-gray skin color also, and those toxins can be very itchy. So they develop pruritus and they scratch, and that can lead to an infection. The bruising, because they're not clotting, platelets are affected. And musculoskeletal cramps, the osteodystrophy, and the bone pain. So I mentioned, I think last week, about phosphorus and calcium being reciprocal. And we're going to talk about that as we go through that system. So let's go back and look. These patients end up in metabolic acidosis. Okay? From that increase in the urea, the creatinine, metabolic acidosis. And our kidneys are not holding on to bicarb is one of the biggest reasons. Because remember, bicarb's our buffer for pH, and it's not doing its thing. So we have a decrease in urine production, but not everybody quits peeing. I've had students come back and say, he's been on dialysis for 5 years, but he had to went to the bathroom twice. But it wasn't good bathroom. It wasn't good pee. It wasn't concentrated. It wasn't removing any of those toxins and things. So they have edema, extracellular volume overload, because they're not able to excrete the sodium. And with sodium comes water, so we're holding on to that. They end up with that pitting edema. They have that fluid overload, which can lead to pulmonary overload, crackles, pleural effusions, pericardial friction rubs. The potassium, we know that had to do with our heart. What's your EKG look like? T waves are peak T waves, inverted for low potassium. Okay. What else is up here? Mag and calcium. Some other things that can cause hyperkalemia, blood transfusions, bleeding, hemorrhaging. With the decreased creatinine clearance, because the kidney glomerulus aren't working, so BU and creatinine go up. And if we have metabolic acidosis and our kidneys aren't working, how does our body try to get rid of that extra acid? Blowing it off. Blowing off those hydrogen ions. So the Kussmaul breathing. Good. So let's talk a little bit about calcium and phosphorus. They are reciprocal. When phosphorus starts to go up, because we are not metabolizing it, the calcium starts to go down. And we activate the parathyroid gland, and it tells that parathyroid hormone gets secreted and says, get me some calcium out of those bones. And it starts pulling it out. Well, that's a safety problem, because now we've got weak bones, and they have a lot of problems with breaks, fractures. And a hyperparathyroidism occurs and starts producing all this calcium. So now you've got high calcium and phosphorus, and it develops this renal osteodystrophy where they develop like little stones. And it goes around the body and gets deposited metastatically, which means far away from where it was done in the kidneys, into soft tissues. So it'll get under their skin, and they'll have little knots, and they'll scratch at it, and they might make a sore. They're prone to infections, not a good thing. But another big place is the heart. Soft tissue muscle there. And it makes the heart stiff. So it affects their cardiac output. They can end up with enlarged left ventricles, hypertrophy, and cardiovascular and infection are the two big things that kill patients with end-stage renal disease. So that's why this calcium business is so important. We need to keep that relationship within normal ranges, and we do that with phosphate binders. It's one of the big deals that we use. Phosphogel, Renal. You've got one on your med list. I can't remember which one I put on there. The other thing that can happen when they the vessels are soft tissue, and if they deposit in there, they decrease perfusion. So they can end up with decreased perfusion to their hands, to their feet, to anything past that. So this is a real big deal. Does phosphorus binders work by blocking absorption of phosphorus out of our GI tract? So when you eat the food, you take the binder. Doesn't help to take it an hour later. You got to take it with your food because you're trying to stop the absorption of phosphorus. Well, it gives them diarrhea. I'm sorry, we'll deal with that. But you got to have your phosphate binders. And they're big old horse pills. They're big old pills. But most patients will, if you bring their lunch and forget their phosphate binders, or bring them at 10 o'clock when they don't eat till 12, they go, no. I don't, I take that with my food. Okay? That's how they work. All right, hypocalcemia. Another thing that occurs with that, how can you tell? What kind of symptoms do you see? It has to do with muscle. Chevette, yes. Good. That muscle, carpopedal, they get a little cramp in their foot, and that muscle will turn. The facial grimacing, Vostek, I don't know how to say it either. And chronically, this is just going to lead to more and more bone loss because the bone is going to be the body's going to be trying to get in there. Very susceptible to breaks. So that cardiac system, cardiorenal syndrome, we talked about how the cardiac and the kidney work together last week. So we see hypertension because of the fluid overload, because of the activation of the RAAS, because the kidneys think they're not getting enough perfusion. That cycle of vasoconstriction where the hypertension is very difficult to manage because the body wants more cardiac output, so it's vasoconstricting, but now we're worsening our kidney function. Hyperlipidemia occurs with these patients due to changes in fat metabolism. So they have increases in triglycerides and cholesterol, the LDLs, the bad ones. So we need to work with them on that with statins. The congestive heart failure, hypertension, anemia, the stiff heart, the increased fluid, we're causing the heart to work harder, and they can get that left ventricular enlargement. And uremic pericarditis is from the inflammation that occurs because of those toxins. You'll hear pericardial friction rubs. They will have shortness of breath, narrow pulse, pressures, and even dysrhythmias and low-grade fevers. But that's from those toxins that are building up in their blood. And speaking of their blood, remember we don't make good erythropoietin, so they get anemic. And not only are they anemic because of that we don't make erythropoietin, but also because red blood cells don't last as long when those toxins are around. That's going to take us like a minute. Red blood cells don't last as long. Normally they might last up to 120 days. They only last about 90 days if we're lucky in these renal patients. So that affects how well we can get that hemoglobin back up. Platelets, our production of platelets is impaired, so they have more bleeding tendencies. White blood cell production is impaired, so they're more prone to infection. That ammonia is generated from proteins breakdown, what we're not able to secrete. They get a lot of stomatitis we talked about, and can have peptic ulcers. They have a higher incidence of peptic ulcers. Neurologically, cognition diminishes, physical impairment. Later on, risk for systemic drug toxicity and adverse effects of their treatments. They have lower perfusion to their brain, and they have toxins that are affecting their cognition. All right, so what caused this? Well, those are our top three right there. And that's why we have to work so hard to manage these diseases. Acute kidney injury can easily lead to chronic, and then infections, sepsis, dysfunction of the organs. And sepsis can lead to decreased cardiac output and overall organ dysfunction and failure. So health maintenance and promotion, what do? Well, we've talked about diet, low sodium, low protein, work on that cholesterol, urine albumin creatinine ratio, that albumin to creatinine ratio we looked at, those need to start being checked if you have a patient who could be in that 1 to 3 stage or is susceptible to developing chronic renal failure. It needs to be done every year to see if we're getting more problems. Try to control infections, watch their fluids, teach these patients how to monitor themselves as far as, I just gained 4 pounds over 2 days. I think there's a problem. I think so too. And adjusting those blood pressures, keeping up with their blood pressures so that they can see when they need something different, when we need to go to something different. Avoiding NSAIDs. It's amazing how many people take NSAIDs. Goody powders. Love those goody powders. I used to love me some good powder because I used to have migraines. And when I had a little aura before I'd have a headache, and if I could get me to a goody powder and a high test coat, that's good. But I also had bleeding issues with that. My platelet counts would drop, so I had to quit doing that. And they affect, obviously now we know that they decrease renal perfusion. So you've got to be really careful with it. Assessment-wise, look at their history. We've been over all of these things that we use to determine if they are at a higher risk of renal failure. Do they have diabetes? Do they have a lot of stones that would affect them? Post-renal, are they at risk for acute kidney injury that can lead to chronic? But look at their history, do a physical, psychosocial labs, imaging. Like I said, that albumin creatinine ratio needs to be checked. Their BUN and creatinine needs to be checked. And if they are in renal failure early stages, then we should also be checking that GFR. Now remember that GFR is not a number I can pull out like a potassium level, it's 4.8. It's calculated. So it's not done every time we draw blood. It has to be calculated depending on your weight, your race, your height, your sex, all kind of different things. But we do need to check it routinely. Those key features for the symptoms, these are your pages in your book. I would correlate some of these pages with your notes because your book is, I love this book. It's gotten more concise, gives you the information that you really need. It does affect all systems, generally through changes in fluids and electrolytes, acid-base balance, and so you have that buildup of nitrogenous waste. And in the community, we've got to talk about these things. What do we do with fluids? Well, this causes that inability to maintain our body fluids the way they're supposed to. Most of the time they end up with fluid overload. So we've got to talk about how to manage that. Diuretics, diet, they need to learn all of those things. Self-weights every day, know when to call, know when to make changes. Cardiac function is because they usually have a reduced cardiac output. Their heart gets stiff and it doesn't work as well, and then we're putting more demand on it by increasing that volume. Okay? What's the next one? Weight loss. Inability to digest, their metabolism of fats, carbs, proteins, all that changes. So a lot of times they'll lose weight, but they'll have weight gain because of the fluids coming on. So we need to help with that and absorption of foods. When you're checking in I's and O's, you also need to be sure that these patients are getting enough calories every day, because they get anorexic and they don't eat very well. Potential for injury. Hemorrhaging from the platelet count being low. Infections from white cells not working right. Anemia. Fatigue. Falls. Bone breakage. Big one. And then psychosocial compromise. This is a chronic disease which changes everything. I mean, your dialysis will be done 3 times a week. You go in for hemo, it takes 3 to 4 hours. It's very fatiguing. You're kind of exhausted when you finish because you have shifted a lot of fluids and electrolytes and your body is like, whoa. So it kind of takes up your whole day. But now there are DaVita, dialysis is probably the most common known one. They're everywhere. And you can, like we have a DaVita over in Enterprise, and if you plan to go on vacation, you tell them where you're going and they set up your dialysis for you. So that you can still, do your vacation like you wanted to. But it does put social restraints out there. Maybe you might not be able to work full time. I mean, it is definitely a life-changing disease process, and it's chronic. So yeah, they have a good bit of psychosocial issues that they have to come to deal with. So, just to be sure you got it all, I added some more about each system. But we can whip through this pretty quickly because we have already looked at it. So we're going to use diuretics for all that fluid and to help decrease blood pressure. But remember, most of those diuretics are potassium wasting. So keep an eye on that potassium. Although usually their kidneys are holding on so much that we don't have that problem. We have the opposite. Remember that 1 kilogram of body weight is a liter of fluid, which is 2.2 pounds. So if I go in and they've taken 3 liters of fluid off of me in my dialysis, I've just lost 6.6 pounds. Awesome. But I don't really want to do it in that manner. And because of that, I'll go ahead and tell you that sometimes these patients, when they have dialysis, after they come off of dialysis, think about the fact that they've had that much volume and their body is used to that much volume. So you take that much volume off and all of a sudden it's going to go, wait a minute, I don't think I'm getting perfused well enough. And it'll activate vasoconstriction. So they may come off of there with high blood pressures, and you just treat it. Block that renin-angiotensin system, get that pressure back down. But a lot of times during dialysis, and we'll talk more about that when we get to it, they have issues with keeping their blood pressure up. We'll discuss that in a minute. Pulmonary, as I said, they can have left or right-sided or both. Congestive heart failure, which can lead to pulmonary edema if it's left-sided, with the pitting edema if it's on the right. And y'all know how to check for different kinds of edema and whether it's right or left. The restlessness, the blood tinged sputum. Their O2 sets are going to be affected more with left. And then our decreased cardiac output. So we have to control hypertension. Calcium channel blockers are one thing we use. ACE inhibitors are probably the most common. They block that RA system. They also help to decrease sodium reabsorption because they alter the aldosterone levels. So they kind of have a little bit of a diuretic effect also to help with that volume. They can cause a little bit of vasodilation. So diuretics, if we go to diuretics and some kind of vasodilators, then we have to be careful about orthostatic hypotension. And they are potassium wasting, so we have to monitor that potassium. The ACE inhibitors are the prills that are going to increase that cardiac output. I lost my little thing here. Calcium channel blockers improve glomerular filtration rate. They improve perfusion to the kidneys. Something like amlodipine and nifedipine. So hypertension control is very, very important. All right, nutrition. A lot of times they are anorexic. They'll be on vitamin supplements. We know that protein is going to vary depending on where their GFR is. We know that they'll probably have fluid restrictions, sodium restrictions, potassium restrictions, phosphorus restrictions. How fun. I did put up a little, I think it's under your study guides, a link to a diet that is good for renal patients. It kind of makes things a little simpler. It has sample diet, meals and things on it you can look at and kind of see what kind of food we're talking about. Injury, remember the bones, drug toxicity, the high phosphorus, so we use phosphate binders, anticoagulants. We also, they have higher bleeding, but because their platelets are lower, but then a lot of these patients get heparin when they get their dialysis because we don't want clots to occur when we're trying to dialyze them. And it takes about 4 to 5 hours for that heparin to wear off. So after dialysis, they don't need to have a tooth extraction scheduled. And if they were to have a wreck on the way home, they would have a high chance of hemorrhaging. Infection, we talked about the toxins, the skin, doing a lot of good care because infection, remember, and heart failure are the two biggies that kill these patients. And the fatigue is going to come from anemia, vitamin deficiency, their nutritional deficiencies. They need iron supplements to help with the erythropoietin production of red blood cells. They need their medicines after dialysis, otherwise it'll just wash it out. And that's it. Oh, I know the other thing was working with them to conserve energy. Because as I said, they're gonna have a lot of fatigue, and they have to kind of build their activities around that and around their dialysis, because the dialysis itself is very tiring. They need a good support system, because there's gonna be things they can't do. The dialysis nurse becomes one of their support systems. As a dialysis nurse, you become family to them. You may have to arrange for them to get there. There's a transportation thing over a taxi company over an enterprise that the nurses know they can call. If they get a patient that can't get there, they can call them and they'll go pick them up for them. So they've developed those relationships over there. But when do we know that a patient needs to go on dialysis? Well, it's not just the GFR. You know, I said when they get down around 15, that usually means it's time for dialysis. Well, they may be at 20. And if they're not able to take care of all this stuff, they need to be on dialysis. They are acidotic all the time. We can't get the electrolytes under control. Their calciums are low and their phosphorus are high. They've got poisoning from those toxins, fluid overload, they're in congestive heart failure, pulmonary edema. We just cannot be the kidney anymore. It is not working. And that usually happens when that GFR gets down around 15, but it may happen at 25. We have to assess all of this as to when we need to start it. So, as I said, we got different places to go. We got in-center hemodialysis. We got home. We got peritoneal. They will all end up needing renal transplantation. There is no cure for end-stage renal disease. They're all going to end up, hopefully, on the transplant list. But if they are I said this, I always say this, and then one day somebody said, well, my so-and-so got one, and they're uncontrolled hypertension. But normally, if you have uncontrolled hypertension, or you are not controlling your diabetes, your A1Cs are always elevated, you're not going to be on the transplant list, because you're going to do the same thing to another kidney. So those things have to be in control. You have to be hemodynamically stable to go through the surgery. So there are some things, but it's usually about a 5-year wait for a transplant. So it's a while, you know, and some patients have died before they could get their transplant. But hemodialysis is what or some type of kidney replacement therapy is used to act as the kidney. Because our kidney can't do it anymore, so this is going to be our kidney. And it all works by diffusion, movement of higher to lower concentrations. Okay? The dialysate and your blood don't mix. But the dialysate, each individual has their own blend, so to speak. And it washes around, I don't think that would open, these little fibers. Your blood is going through these little tiny things, and as you can see, they are very, very tiny. You kind of see them through there. And then it pulls out and puts in whatever it needs to and cleans out your blood. Now with hemo, go that way, go back in that way, and y'all go that way. Look at it. That's a home dialysis filter. And as I said, it takes about 3 to 4 hours, and we do it 3 times a week. They're usually on Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday schedules. And they come in, they all have a dry weight that will look at, okay, for this patient to be, you know, hemodynamically or homeostatic, this is what their weight needs to be. So if my dry weight is supposed to be 150, and I come in and I weigh 155, then they're gonna try to pull 5 pounds or, I don't know, a little over 2 liters of fluid off of me. I may do okay and get that all off. I may get hypotensive during it. And we'll talk about what to do if they do. But how do I know how well my dialysis went? We don't take blood work every time. When we do, there's a nice little KR that looks at and that gives you a good idea of it. But the best way is to look at vital signs and your weight. They will weigh you every time you come in, and then at the end they will weigh you again. And that tells them how much fluid they pulled off. Because 1 kilo is 1 liter of fluid. So a lot of patients are anticoagulated, get heparin, because we don't want these things clotting. And this, the other thing is, I told you it wasn't sterile. As it can be warmed, it makes it the diffusion go a little quicker. Sometimes if your pressure drops, they can slow that down so it doesn't, so it takes a little longer. And the heparin, okay? So here this is where the baths are put together, the fluids that are going to be running through the machine. This is the machine. It hooks up arterial side and a venous side. So whatever you're using to dialyze, runs it through the machine, blood goes out, goes through here, I think there's a filter right there, runs through the dialysate, pulls the toxin out, blood goes back in. And it runs for about 3 to 4 hours. Sometimes they'll get pressures drop, slow it down, cool it off so it doesn't go so fast. Sometimes the pressures keep dropping and you have to put fluid back because you pulled off too much. Raise their feet, that should help the pressure come down. Sometimes they have to stop it if they get what's called disequilibrium syndrome, where they can't really get the pressure back up good. So they'll stop the dialysis and then treat their pressures. So let's look at how they hook up to that machine. They've got to have something that has high volume and easy access to the vascular system because they're cannulating. 2 big old needles about like my finger, big needles. So a couple ways. We talked about the central line that you see used with the hyperperfusion, or you can dialyze through that also, but it's temporary, okay? What we want to do is either get a graft or a fistula done. A graft is actually a synthetic type material that tunnels under the skin and attaches on the venous side and the arterial side. And it's self-sealing so that it can be cannulated multiple times. The big daddy is to do a fistula, where we actually take the artery and the vein and anastomose it together so that you come up with a bulging, nice, high flow area that you can cannulize easily. Now, these things, fistulas, have to mature. And what that does is that helps that high flow and pressure in here will make the vessels grow, get more, their walls become thicker so that you can cannulate them over and over again. So it takes up to 2 to 3 months for that maturity to occur. That's why we start doing and talking to patients about their options before we get to the point that we got to be on it. They're coming out with some that take less time to mature. I don't know a lot about those yet. I need to work to find that out. But one thing about those, as they mature, you know, we don't want them lifting heavy objects, but we do want them exercising those arms a little bit so that we have good muscle to keep the fistula supported. So we're going to go through one of these sites. Here's a graft right here that's connected between the two up here, or you can see it down here where it's spun here. Legs, femoral artery, they do what's called a necklace, where they use the subclavian up here. So lots of different places, but we have to have vascular access when you do hemodialysis. So here's our double lumen. One is arterial blood, one is venous coming in. Venous goes in, arterial comes out and gives the body that nice clean blood. Dressing change every week. RN patient wear a mask, turn their heads, no alcohol. Alcohol dries those catheters out. I know Flowers used to have a day, like every Tuesday, they did all their CV line dressing changes. Didn't matter if you came in Monday, your dressing got changed on Tuesday. That way they knew, once a week, every dressing in the hospital was changed at least once a week. I assume they still do that, I don't know. Here is a nice, pretty fistula. It's the book, the picture in the book is a lot better, but it's big. How do you assess whether it's working or not? Anybody know? Feel the thrill, hear the brew. So you're going to hear whoosh, whoosh, whoosh noise when you listen, and it's going to feel like little, I don't know, an army of ants underneath there moving. And there's a big pulse in there. If you don't feel that, then you need to notify the physician. That means it's clotting. And they can get in there and clean it out to a certain extent. Eventually, though, they won't be able to use it and they might have to move to a different site. 5 years is a good time for these things to last. So if you got on dialysis when you were 26 years old, there's only so many places if you don't get on the transplant list. No lab draws, we talked about that, no lifting, but we do want them to keep that musculature enough that it supports. So here's just a symbolized picture of how the dialysate is stored, comes, washes around here. It's a good picture in your book that shows how the electrolytes and things exchange. It's all for diffusion. And then the blood has come out of the vascular system all nasty and full of toxins, goes through here, pulls it all out, and we go back arterially into the body. Okay, y'all want to pee yet?
Yes, ma'am.
All right, let's take a break. And if my enterprise people have done your thing, you can put them back up here.